Megan Nicholson, and I'm the Director of Marketing at Welby. We're happy you've decided to join us today for a practical guide to implementing bundled payment programs. A few housekeeping details before we get started. This webinar is being recorded, and you should receive a link to the recording and slides tomorrow by email. Please feel free to share this webinar with colleagues who could not attend today. A question and answer session will immediately follow the presentation. If you have a question for our speaker, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by Welby. Welby's Episode Performance Management delivers the tools you need to tackle the new world of accountable care. From pre-procedure preparation to inpatient care to home recovery, Welby's solution includes guided experiences for patient engagement, care coordination tools for team efficiency, and real-time analytics for episodic intelligence. To request an executive briefing on how it could help transform your service line for bundled payments, please visit us on the web at welby.me. I'd like to introduce our speaker for today. Sheldon Hamburger serves as the principal of the Aristone Group, a Raleigh, North Carolina-based healthcare consulting group. With focus on helping healthcare enterprise organizations address emerging trends, Aristone provides expertise in strategy, process, and technology. Sheldon, I'm going to hand it over to you, and you can take it away.
Thank you, Megan, and thank you to Welby for hosting today's webinar. Good morning, good afternoon, or good evening, as the case may be for those of you attending from wherever you're attending. I'd like to start by polling the audience for a couple of questions just so I can see and you also can see who is attending and what stage of bundle payments you're in. So I'd like to start with this quick poll here. Megan, you're going to drive the poll.
Yes, our first poll asks what your role is. Are you a provider, payer, patient, or otherwise? So just click the radio buttons right on your screen and we'll see who we have in attendance here. Like we've got 70% of the vote in, so stragglers, get your vote in on screen, and then we'll show the results. So Sheldon, it looks like we have 52% providers, 2% payers, no patients, and 46 say others.
Great, okay, and then the second question.
Now we want to know where you're at in your bundled payment initiative. Is it only in your mind, being discussed? Are you currently under construction, or is it up and running? Take a minute and select the answer that best fits you, and we'll share it with everyone in a couple of seconds. Okay, it looks like we've got 21% just a vision in their mind, 28 are in discussion, 45% are currently under construction, and 6% are up and running already.
Thank you for handling that brief survey, Megan. It gives us all a sense of who we all are here on the call.
And Sheldon, if you just want to click the share my screen button so we can see your slide. There you go.
Very good. So I've attended quite a few webinars myself, and I know that as you're listening in, probably have a bunch of other windows open, doing emails and other things going on. And as a matter of fact, when I present in person, it's kind of the same thing. But I always begin by asking everybody to stop what you're doing, because I'm going to deliver this entire presentation in 30 seconds or less, and I wouldn't want you to miss it. So if you take away just one thing today from this presentation, it's this. Your next CFO isn't coming from general orthopedics, general surgery, or general hospital. Your next CFO is coming from General Dynamics, General Motors, or General Electric. That's it. So if you got other stuff to handle, I completely understand. But if you want to know more about implementing bundled payments, I'm going to be talking about that for the rest of this session. And the reason I make a statement like this, and I do a number of webinars on various topics, I always start with this one, because healthcare is truly changing, and these new value-based programs, of which bundled payment is a part, are truly game changers, and they're not just in a semantic way. It's in a very real way, and that's because healthcare itself has now become a commodity. What I mean by that is this: if you're a patient in America today, it's a great time to be alive. There are just unbelievable types of treatments and varied types of treatments available. There are just miracle things that didn't exist 50 years ago, 20 years ago even, and there are new things coming out all the time. And despite what we keep hearing, everything's getting cheaper. The drugs we're seeing are getting cheaper. The cost of the procedures we're getting are going down, and you don't have to travel to the far ends of the earth to get them. If I want to get a hip replacement, I can get it here in town, and I can probably get it at half a dozen places, if not more. So, it's a great time to be alive. 100 years ago, you got sick and you died. And now the antibiotic that would have cured you is virtually free. So if you're a patient, it's really great. But if you're a healthcare provider today, oh, it's a lot tougher. Because in America today, if you want to get healthcare, you just go to the end of the aisle between the Doritos and the Coke. This is a picture of a Minute Clinic, a retail clinic at a local CVS. I took a picture I took myself at a CVS near my house. I live in Raleigh, North Carolina, not a Tier 1 city. It wasn't too hard to find one of these. And it's pretty easy. You go in there, you get your care, and you're cured. 1, 2, 3, walk up, sign in, feel better. Forgive the glare on that screen. I'm not the greatest photographer, but this really is kind of an indication of the direction of where care is going, at least in the minds of our customers, formerly known as patients. Last year, the American Osteopathic Society did a survey trying to figure out how patients choose their doctors. And the criteria that the patients cited overwhelmingly resemble those same criteria that they use to buy a television set. The #1 criteria for choosing your doctor by far was, do you take my insurance? Are you in network? And that's because it's cheaper, right? Lower out-of-pocket cost. Second most popular reason people chose their doctor, bedside manner, which is customer service. Then it was location, hours of operation. People did not cite where you went to medical school, how you finished in your class, where you trained, and how you rated in U.S. News and World Report. This is how our customers are viewing us today. In a world of value-based payments and bundled payments, we need to be responsive to their perception because that's the reality of where we are. Just to set the tone here, when we're talking about bundles within an episode, I'm not going to go through a whole litany of definitions and history of things. We're talking about the financial responsibility that you're taking on as a provider. So if this proverbial pie is everything associated with an episode, that red area is what you're taking on. And the key in bundled payments of this commoditized services we're rendering is this: we're delivering care at a fixed price. And this is really essential to understanding as you're going through implementing your programs. The most important thing is inculcating a culture into your organization that understands that we're delivering fixed price care in a world of commoditized care, and our patients are customers. Now, the theory behind how this got started is really cost shifting. We know that. That's the payers trying to shift the cost down to providers, and simply because they feel that the providers have a much more, let's say, intimate relationship with their patients, and they feel that they can more greatly influence the care. So the payers are realizing they just got to give up on trying to control the care. They can only manage the experiences, and so they're shifting the risk downstream. Now, we've seen this before, and a lot of people object to getting on board with bundled payments, and if you're just getting started, you're going to hear this. People are going to tell you this is nothing more than managed care of the 80s coming back to haunt us. It's more HMO, PPO again. It isn't. The world's a different place. Healthcare is a commodity. Our patients are customers. It's a different world, and this value-based type of arrangement like bundled payments is really here to stay. So why do people participate in these? Well, first of all, it's profitable. We can figure out how to do it. What's interesting is that those organizations that have figured out how to do it aren't really sharing their secrets. On the engagements that I consult on, I can tell you the NDAs are very tight. Nobody wants to share information about how successful they are because the person or the organization they'd be sharing it with is their competitor. Another reason you definitely want to get involved in bundled payments is you want to be first to market. You people who are first are going to be setting the standards. If you come in late, you're going to be playing by somebody else's rules. In addition, you're going to be able to capture more market share because the arrangements with payers on bundled payments is the patients have virtually no out-of-pocket costs. It's very typical that the patient will have no out-of-pocket costs to come to a bundled payment provider. So you're definitely in a preferred position vis-a-vis your competition. But what's more interesting to me is you can also increase your market size. I'm sure you've read about the bundled payment arrangements going on with the major employers and groups like Mayo and Cleveland Clinic and others, where they're flying patients in at no cost. They pay for the patient's expenses and their caregivers. So if you're an orthopedic practice in Tempe, Arizona, and you're worried about your competitors next door in Phoenix, you should start thinking your competitor really is on the other side of the country over in Cleveland. New realities opening up. What if you don't participate in bundled payments? If you're thinking about it and you're getting objections, well, it's pretty simple. You're going to lose patients because if you're not going to do it, somebody else is. And when the calculus of the patient is out-of-pocket expense, and we saw it's the #1 criteria they use to choose their doctor. When it becomes 0 for a bundled payment provider, you're going to lose patients. So the only question I ask people who don't want to participate in bundled payments is this: how many patients do you have to lose to go out of business? Clearly, if you lose all your patients, you're out of business. What if you lose half? What if you lose a third? What if it's only 10%? Could you still stay in business? And as more and more organizations take on bundled payments, if you're not part of this, you're not going to be around. So with that background, let me move right into our guide to implementing bundled payment programs. I'm going to take you right down the checklist of things to do and lessons learned. First, we'll talk a little bit about how you get started in these programs, things to be thinking about, and then issues associated with determining what goes into your bundle. Remember our proverbial pie there. What are you going to include? What will you not include? What bundles you want to handle? Then we'll talk about contracting. There are a lot of models out there associated with contracting for bundles. We'll talk about what some of those are, what's working, what isn't working, and some of my personal biases. Then I want to talk about workflow, a little bit of a pet peeve of mine, and we'll talk about why that is, because it's very important that whatever you do involving change fits the workflow of the organization. We'll talk about cost management, which is hands down the most difficult part of doing this in healthcare, only because we're not very good at it in healthcare, by and large. And finally, we'll talk about how you monitor your performance in this, get feedback so you can continue to grow and enhance your project. So, getting started with the project, #1 issue, somebody has got to be leading this in the organization. Somebody's really high senior who's a visionary and can see where this thing is going and is a true believer, because their role is going to be to inculcate a culture of true character transformation in the organization. People are going to be interacting differently within your organization. You're going to be interacting differently with your patients. And you have to be completely on board with this because it's a total turnaround how you're going to be operating going forward. You're going to want to put together a multidisciplinary team. And key to that is getting physician buy-in. A big part of bundled payments is that you're going to be changing your care pathways and standardizing them. And you can't do that if you don't have physician buy-in on this, and they need to be leaders in this. So you want their buy-in early and you want it often. But you got to bring in everybody else. It's got to bring in your complete staff. It's got to bring in other areas of clinical staff. It's got to bring in financial folks. You should bring in people who may not be directly related to what you're doing. In other words, not employees, for example. You want to bring in outpatient rehab people if you're not operating a rehab clinic, or other inpatient people, or home health care people, and even bring in patients. You're going to change how you operate. You're going to change how you interact with your patients. These are your customers. At some point, you need to bring them in to explain what's going on. Get their feedback on some of the process changes you're going to be making to be sure that you're not missing something that's going to be important to your customer. You're going to need to establish baselines because you need to know where you're at before you know where you can go, which means you're going to have to gather historical information to understand how you're rendering care today so that you can know when you render care differently going forward, how things are going to be different, whether you're making progress, which gets to identifying your key success factors, sometimes known as KPIs or key performance indicators, specific metrics you can use to measure whether you've achieved your goals. So whether you're trying to measure readmissions or infection rates or patient satisfaction, whatever it is, you should know where you're at now, set goals for yourself, measure as you're going, and see how you're doing. And finally, the hardest part, you're going to need to build in cost accounting procedures and models. And you need to be able to identify costs all the way down to the case level so you can determine why some cases are costing you more than others. And we're going to talk about this. It's by far the hardest part. You need to start thinking about this and planning for this from the very beginning. So these are really the basic things that you should be doing and taking into account as you embark on your bundle payment project. And sometimes even before starting, because you may determine going through this that you're not yet prepared to do this. So before you get started, you may want to make some adjustments within the organization. And don't be afraid to bring in outside help to prepare yourself to move on and launch a project. So once you've decided that you're ready to get started and you've got the leadership in place and you have your ideas of where you're going with this, you need to start to determine what will be included in your bundle. So remember this, number one thing, when you're talking about building bundles, you're building a model of care. That is, you are trying to define what your, I'll use these words loosely, normal, typical, routine type of patient is. Because that'll help you determine what goes into building this model. Don't forget, you're selling this at a fixed price. So you need to know what pieces go into building the typical model. There will be variations, and you'll build that into your pricing structure. But you're building a model. Now, you can do acute bundles. You can do chronic bundles. Today, we're just going to talk about acute and with focus on orthopedics. You're going to have a healthy competition going on as you go through this discussion of building models. There's going to be a need to limit your financial exposure on these things, or your costs will be, and your pricing will be too high, and nobody will contract with you. In the meantime, there will be a push on clinical to do everything possible to maintain quality. There's a healthy balance that you're going to need to strike. So don't be surprised when you run into this a healthy competition between clinical and financial. That's why they both need to be involved in the design process. Now, you're redeveloping your care models, and keep that in mind. So you're going to be delivering care both clinically and even logistically to your patients in a different way. And finally, you may find yourself adding services to your bundles. Now, today, you may be doing only surgery. You may decide you want to do rehab as well and take that on, and we'll talk about how you may want to do that. In addition, you may want to take on services such as travel to fly people in. Those are non-medical services. So building those may be a component of your bundle as well. So with all that, where do you begin? Well, it's pretty simple. You begin with what you're good at because you can control it. If you are a hospital and you have areas of excellence, you may want to start there. If you're an orthopedic practice, don't start with cardiac bypass. I'm pretty sure that's not going to work for you. But key to this is you have to be doing high volume. If you're not doing high volume, it's really easy to lose your shirt real fast, and you'll see why. And these go hand in hand. If you're really good at it, you probably do a lot of it. And as you're going through this process, there are a lot of questions that are going to come up. And don't be surprised to see these types of questions, and don't feel you don't know what you're doing, because it's very typical, such as what am I including, what am I not including, trying to figure out what we've done in the past and how we've done it. This is always a sticky one. Is something we're doing redundant, or is it unnecessary? A lot of people, get a little put off by that, but you gotta address that question. You want to find out where you can leverage control, and then a big issue is what causes outliers. And these are patients whose care costs more than the quote normal, or more than your model. We'll talk more about that. So where do you get the answers to these questions? Where we always get the answers to questions in healthcare, in claims data. The reason we use claims data is pretty simple. It's structured data. We've had it for a long time. It's consistently coded. We know how to manipulate it. We also have a lot of the claims data internally. We can also get it externally from our payer partner, and they truly are a partner in this. And this is always a struggle in dealing with payers and the contracting process. This has got to be a win-win. It's not a win-lose. It's been an adversarial relationship in the past. It's got to be a partnership going forward. So being open and transparent about sharing data and results is going to be key. So a lot of the data you're going to get to answer your questions is going to come from claims. Now, there are commercial products that are out there that can help you out with this. There are products out there from companies like there's a Prometheus model, it's not supported by SAS. MedAssets is a company that makes on-symmetry ETG. Some of you are probably using Trizetto, Optum. Aver Analytics is another company that makes products in this area that can help you analyze claims and other data in order to help you build your bundle model. What's really interesting about sharing all this data is you're going to get insights into things you never knew before about your patients, and even about how you operate. So this type of analytical data is going to lead to help you out in a lot of ways, and you're going to see why. One area you hear, and the term you hear about this a lot, is analytics, where you're analyzing this data to typically look for high-risk patients because you're afraid they're going to cost you more, and they're also associated with opportunities for savings. But in addition, using analytics to help you identify low-risk patients can be equally as important. Low-risk patients need less attention. in most cases. So you don't want to be devoting too much attention to patients who don't need it when you can be devoting attention that's needed to more high-risk patients or high-need patients. Now this graph here exists for all, in general, exists for all bundles. And this should be tattooed on the inside of your eyelids. This graph and what it represents really is should be top of mind all the time, because it really explains what things look like now and where your opportunities are for success. And let me take a little time to explain what's on here. It's somewhat of a bell curve, as you can see. This red line is number of patients. And as you can see here, these are number of patients. This is a fictitious model I made. And over here is the total reimbursement. This came from claims data. And it's very important to understand when you're looking at claims data, you're looking at reimbursement. This isn't cost data. I can't tell you how many times people talk to me about this, and they're using the word cost. This isn't cost. It's reimbursement. Now, reimbursement can be a proxy for cost. That is, it's related to cost. But in a world of fixed price care, we've got to be really careful when we're talking about cost and talking about price. They're different things. So this is reimbursement here. You can see how many patients are reimbursed at different levels. And I've broken the levels here into tranches of about $2,500 across the board. What you typically see in bundles when you look over time and enough patients is that the reimbursement you get generally falls predominantly in some price range. This is typically what you're getting paid, more or less, in a range here of about $20,000 to $30,000 for most of your patients. This is basically the market price for what you're selling. Out here are more patients, and there are fewer at these higher ranges. These are patients costing you more than the norm. That's the norm over here, more than what you normally would be charging or collecting today, in the future, charging going forward. So these patients here are aberrations. And the more you have of them, and the more aberrations you have, the more money you're going to lose if you're charging this fixed price down here. And the key to being successful in bundled payments on the financial side is how do I drive more of these patients from this side of the graph over to here. Now what I've done here is I've broken down into dark blue and light blue two portions of the reimbursement. The dark blue being your model reimbursement, the light blue being what's often termed PAC, potentially avoidable cost. These are, and again, the term of art cost, you know, it could be cost, but it's also reimbursement. It's avoidable reimbursement if you look at it that way. And it truly is. These are services or products that were used in treating these patients that might not have been necessary. They may have been redundant, unnecessary, done for no reason at all, done because we always did it for whatever reason. And a big challenge you have in bundles is how do I understand what these light blue areas are, drive them down so that I'm all in dark blue and moving over to here. And that really is, in a nutshell, this graph, what bundles are about on the financial side. And you should always be thinking in everything you're doing, how am I going to make this graph move all these patients down to this area here? As I said, you want to tattoo this thing on the inside of your eyelids. So keep in mind you're redeveloping your care models when you're building these bundles. So what you need to do, obviously, is review what you're doing now as a starting point. But you also want to be looking at industry clinical protocols and industry best practices to see if there are things that could be done differently and or better. And don't discount your own best practices. Just because there's an industry standard way of doing something doesn't mean that you don't have a better mousetrap in your organization. So don't be afraid to take what you've been doing in the past, what others may be doing, and add your own twist to it. A lot of times it can be a differentiator. You also at this point want to be starting to develop your quality metrics, again, your KPIs, your metrics of quality. And one metric may be, for example, how much blood you're using during an operation. And maybe that's a metric that you want to try to drive down. And again, you're trying to reduce avoidable complications. And so reviewing the past and past cases, even going down to patient charts and looking at what happened, can give you insight into what causes some of these complications. Other KPIs you're going to want to look at are going to be financial measures of what's going on. For example, you may want to look at average cost per patient, average margin per patient. And what you're trying to do here is cut out the fat, things that aren't necessary, and at the very least maintain your profit margin, but hopefully improve your profit margin. All right, so you decided you want to get started on your bundle plan. You've got a visionary and you found a way to develop your bundles to figure out what's in there. Now you want to go out and sell them. So you got to go out and sign a contract with a payer. So the first thing you got to figure out is who's the contracting agent with that payer. Are you going to sign a contract with the payer? Is it going to be another group signing a contract and you're subcontracting to them? What is in your bundle? Are you doing everything? Remember our pie chart, or are you doing just some of this? And what is in your bundle and what is not? The more scope you have, the more risk you take, but the more control you have, and the more upside potential for making money. I'm a big fan of taking everything, because with everything you get more control and you get more upside potential. We'll talk about that in the contract models. You should also be looking at what non-medical services you may include in bundles. These non-medical services, as we said, might involve travel, and it might involve other things, as we'll see. There are also business models you have to consider. Do you want to do joint ventures? If you're an orthopedic practice, does it behoove you to joint venture with another orthopedic practice in your area in order to drive more volume? That might make sense for you. Might be a joint venture, might be a merger. There might be a physician-hospital organization that you form. You get a hospital on board rather than using them as a resource. We'll see that in a moment. Then you got to consider the legal structure. They're going to put together. Obviously, legal is going to need to be involved in this. And when you get involved in joint ventures or in mergers and things, and or PHOs or other types of organizations, governance is key. You got to get that straight from the get-go, and obviously, to determine policy. You're going to have all kinds of challenges. You've seen this before: Stark, RICO, et cetera, et cetera. Even state regulations about risk sharing and quote profit sharing. Whatever organization, whatever structure you put together, it has to be a win-win. It's a new model, so you have to have an alignment of interests. And the way to align interests is through money. So figure out how everybody's going to get paid. That will align your interests. And that's the ultimate equalizer, is aligning your payments. Excuse me. The great thing I like about bundled payments is an opportunity to change the game. All the rules we've had and the way we've been contracting in the past, we can renegotiate now. And this creates something that I really love, which I talked about before, which is called steerage. If you can negotiate with your payer to reduce or eliminate out-of-pocket costs to the patient, so that for bundle providers, then you as a bundle provider have a preferential position within the decision-making process of your customer. As we saw, price is king to them. So being able to be involved in a model like this makes a lot of sense, and it's something you should be pushing for if your payers aren't already doing this. Now, other models we're seeing, the more common ones, are models called gain sharing and withhold. I'll talk about those. Now employers are starting to bypass payers and going directly to providers, which opens up a new opportunity for you. Then there are physician-directed models. It's commonly thought that hospitals are on top as the contracting agent, but that's not necessarily the case. Providers tend to have more direct relations with patients, and so it may behoove them to be the contracting agent for bundles. We'll talk about that. And then here's another contract people don't often think about. It's the contract that you should be having with your patient. And I'll talk about why that's important. So these models called gain sharing and withhold, they really are shared savings models, another term for them. If you're involved in the Medicare initiative, you know about that. And this is where you establish some sort of threshold for savings, and you try to reduce the spend. And to the extent it's reduced below the threshold, that's called savings. And then the savings is shared between the parties. So that the payer may share with the provider, the savings of $1,000 per case gets shared 60-40, 50-50, whatever you negotiate. The way it's implemented, though, is interesting. You bill fee for service and periodically true up. So what's happening is you're sending in claims, you're getting paid on a fee-for-service basis, but at the end of every case or end of every quarter, you're going to sit down with the payer, and you're going to figure out how much the average case costs and were you above or below the threshold. And this creates the game of my claims versus your claims. And the big arguments about whether you saved as much as you think you did and the payer says you saved less, and how you can prove your case. And then you get into other claims that the payer can provide, claims that you don't have because you didn't submit them and you have no way of verifying them. So this gets into the complications of cost of implementing models in this way. And remember our proverbial pie there. If you're not rendering the services over there in blue, those claims are coming from somebody else, and you have no way to see where they are, know what's happening, and as importantly, not know what's happening in real time. Now, as far as the threshold goes, you're basically going to wind up indemnifying the payer. And what that means is you're going to pay for anything over the threshold. So because that's the clawback provision of these types of contracts. So what happens is somebody goes out and abuses the rehab system, going to rehab every day for the next 3 months, and all of a sudden the case cost goes through the roof. You had no control over it, or you were supposed to have control over it because you were supposed to tell the patient or get the patient to stay within a certain rehab network, but you weren't able to. And so now you're going to take the hit on that. So that becomes an exposure that you have in these types of models. Another issue is how you're going to distribute the savings and who's going to distribute the savings. If you're going to be sharing savings on multiple providers, who's the third party who's going to verify what the savings were and what the distribution is going to be according to the contract that everybody will live with. So these kinds of distribution models are common, but they're very complex. And providers and payers will tell you that it's very costly to try to implement these things. And payers are concerned that they're paying twice for this. They pay these bonus savings once under bundle payments, and then if this is part of an ACO, patient's part of an ACO, they're paying the same distribution under an ACO model. So despite this, payers are very supportive of these models, and they are reporting that they're seeing a lot of savings. Now, another model we're seeing more of, and you're probably reading about this, is employers coming directly to providers for contracts. So they bypass the third-party insurers, which makes the employer the payer. That's really interesting because if the employer's a payer, how do you bill them? Maybe you don't have to send claims. You just send them a bill out of QuickBooks. One hip replacement, $25,000. That would be really great. So in this model, the provider is just another vendor. From the employer point of view, and this is why they figured this out, you're another vendor. If you're Walmart, you're buying tires, you're buying greeting cards, housewares, and healthcare services. You look like one more vendor to them. So you should be cognizant of that when you're dealing with them. Now, this gives you the opportunity to go out and solicit business from these employer groups. So if you've got self-insured employers in your local geography, this is a great thing that you can go out and solicit directly to them if they're not already trying to solicit these type of arrangements from you. Now, I mentioned physician-directed models, and here the physician is the contracting agent. The hospital is nothing more than a resource. And what the physician practice is doing is they're buying hospital nights and OR hours. So you go to the hospital, or maybe several hospitals in the area, and you put it out to bid. I'm going to need 2,000 hospital nights and 5,000 OR hours this year. What are you charging me? And maybe the feedback from the hospital is, well, for 1,000 nights it's this. If you get to 2,000 nights, it's 2% less, and for 5,000 nights, it's 4% less. Again, we're getting into a world of commoditized care and commoditized business arrangements. These are going to become more and more common type of business arrangements. And your new CFO, who came from General Motors, knows all about that because he or she lives that world for every day and does that for breakfast. So how would you bill something like this? This is one of the questions that gets in. The hospital is going to send you a bill like a supplier. So just an interesting type of development. And then there are other services you're going to need to contract for. We talked about travel. But what about including a gym membership for 90 days while your patient's going through rehab? This is a real plus to the patient. Or nutrition consulting, or getting a nutritionist involved in this, and picking up that cost as part of your bundle. It creates a differentiator for you and it's good for the patient. It creates a better patient experience, and it's a way to draw in more customers. And you could even consider paying for their painkiller meds. A lot of these things are cheap generics. You roll that into the bundle, and that's just another thing you could be doing. Don't forget that ultimately, where we're going with this is you're going to be billing payers fixed price. Right now, the preponderance of the models is fee for service. Everybody looks at that as going away. It's going to be a fixed price type of bill. So the more that you can drive down your internal costs and the more you can figure out ways to include more things, the greater the differentiator you can create to attract more patients and to create a better patient experience. Now, whatever these costs are, you're going to have to wind up linking with your cases, so just keep that in mind. You may or may not need to include these in your contracts, by the way. You may offer these outside of the contract. It may not be of any interest to your payer, whether you're going to offer nutritional consulting or a nutritionist as part of the patient experience. So just something to keep in mind. The last thing I want to talk about in contracting is patient-provider contracts. These are contracts you want to sign with your patient. And the reason is your patients are out of control. I don't mean they're crazy. What I mean is they exercise control over the bundle that you don't have. They can choose to, let's say you're going to take on a bundle for the entire hip replacement experience, and you're going to take on rehab as well. So you need that patient to go to your rehab facility, the patient doesn't go there and they go to another rehab facility, that facility is going to bill the payer, and you're going to wind up indemnifying them and paying for that. And you need to know when that's going to happen. So tools like Welby's tool that helps keep you engaged with the patient, let you know that this is occurring so that it doesn't get too far afield. But the problem is that most people don't have tools like that, and the patients wind up going utilizing services outside of your knowledge and your control, which means you wind up getting beyond the thresholds of your bundle. So a contract like this binds the patient to compliance with the bundled rules and gives you recourse to go after the patient to get reimbursed in the case that they wind up going to a non-network, if you will, provider. Now, you don't want to be getting involved with going after patients. That's something we're trying to avoid. Don't forget, if you go to a fixed price care model with your payer, you don't have any patient receivables. It's a great thing. So you don't want to create one by this, but you should have it in writing with the patients that they have responsibility. It helps you drive home the message of your bundle, so don't be afraid of doing this. So now you've embarked on your project, you've decided what bundles you want to have. You want to get into contracts here. We talked about the contracts. I just want to close on contracting, talk about exclusions and inclusions. Feel free to exclude conditions such as obesity, diabetes, etc., and not bundle those, or have a separate bundle. Perhaps you have your normal, quote, normal model, routine model is one price, $25,000, and patients with certain comorbidities are $37,500. You may want to exclude certain services, as we said. You remember the pie chart. Maybe you'll exclude rehab. And warranty services are a great thing to offer. I will cover any readmissions due to problems with a surgical site in 6 months. So I'm doing a hip replacement, $25,000, 6-month warranty. It's like getting your car fixed. Again, commoditized care, fixed price, you got to be thinking along those lines, and your customer expectations are going to start to align this way. Be prepared to offer the things that they're going to be expecting. Finally, contingencies. This is a story of a client of mine. They had an ongoing bundle, and one of the drugs they prescribe on discharge, I think it was a blood thinner, I don't remember, it may not have been that. They used to always prescribe the generic. It was a single source generic. The generic company couldn't make the product for 6 months, so they had to dispense the brand. The cost difference internally to this organization between the generic and brand ate up and exceeded the profit margin. They wound up losing money on every case. They had nothing in their contract about this. They had to go back to their client, and the client fortunately was understanding and agreed to make them whole. So for 6 months, while they didn't lose anything, they didn't make anything either, and that wasn't a good situation. So think about all the kind of contingencies you might want to build into your contract. So now you're contracted, you're ready to deliver, and now you get into workflow. This is a real pet peeve of mine. Despite the system, and I come from an IT background, changes that we've been doing over the years for many systems we implement, we always seem to fail to understand how these systems function in the real world. And that's why people run their own systems side by side with what you implement. They have Post-its all over their computer screens. They run separate spreadsheets, looking at data, and then nobody's data ever matches up. Workflow is absolutely key. And what you've got going on here is you're going to be operating a fee-for-service and bundle payment treatment model simultaneously in your organization. That's going to create challenges. In addition, you're going to be billing both models simultaneously. And there are no standards here. As I said, nobody's talking, nobody's going to tell you how to do it. So if you can bring in any kind of outside help, it's a big, big plus for you. And so as I said, limited lessons learned that are out there. Anybody who's got success has a competitive advantage, they're not going to share it with you. So let's talk about how we treat bundled patients. We're changing the care pathways, right? That's what we said, because we're changing the care model. So we need to educate our staff, our internal staff, and even our business partners on how we're handling patients. We're going to need to make changes to our EMRs. We're going to need to make changes to our financial systems and possibly other systems. We want to avoid introducing any separate systems that and separate workflows, because they're just going to get disjointed, and we're going to wind up having 2 sets of data. We are looking to maintain a single point of truth, a single source of all information, so we can do our analysis and go back to that chart that's tattooed on the inside of your eyelids. In order to get the data you're going to need to make progress on there, you need to have a single point of truth. So you need to have a workflow managed in that sense. And you're going to need to support multiple bundle models, because you're going to have different payer contracts, and your one system needs to support multiple models. And you need patient support tools, tools that will help your patients get through the bundle process. And as I said, Welby as a product like that, and I don't mean to plug in the product, it's just that having a product out there that can help guide a patient through the bundle process can only help to reduce your frustration and reduce your internal cost. So are we going to treat our bundle patients different than our traditional patients? Well, yes and no, as you probably expected. Standardized care benefits everybody, so we're going to see lower costs in standardized care, but once we standardize the care, even our fee-for-service are going to gain from that. You're going to need dedicated case management, so you're going to need to have somebody on staff dedicated to managing these bundled cases to understand how they're flowing, to constantly get feedback on how that's working. Things like discharge planning and can be done even before the patient actually arrives. So think about things like that. And you want to be tracking these things on an ongoing basis. On an ongoing basis, you want to track your costs, your activities, all services being rendered, because you need to get real-time feedback. I'll talk about that under costs. Ultimately, what's going to happen is your models are going to merge and all patients will be treated the same way. And this has interesting feedback and interesting ramification I'll be talking about soon. Regarding billing, okay, you're billing fee-for-service and bundle patients simultaneously. Now, the effects on charge capture are interesting because we capture charges today in order to generate claims. And bundle payments, we need to capture costs. So we're going to need to establish some relationship, at the very least, between charges and costs, but it's not just that. We're going to need to figure out how we're going to capture these costs on a regular basis. I'll talk about that under cost management. Now, also, we're going to be billing fee-for-services for some of our bundle models, as I talked about in those gain-sharing models. So in other cases, you just want to bill a single fee. So are you going to use a dummy 837, an outpatient transaction, make up your own CPT code for a single fee? Or are you going to use a conventional invoice, in the case you're not billing fee-for-service, of course? Can you generate invoices out of QuickBooks? So think of this. Would you rather be capturing data to bill this or this? And this is where we're headed. And my nirvana in bundle payments is you're billing out of QuickBooks and this whole world of claims goes away. Think of the administrative simplification you're going to gain out of that. And by the way, ultimately, when it comes up to squeezing costs, administrative simplification is going to be one of the costs that has to be squeezed out. And eventually, this issue is going to come to the forefront. Now, this also affects payment processing. Now, fee-for-service, you know what you're getting paid. Every charge gets an associated payment. But it gets a little tougher when you have a bundle payments model like withhold. So in a withhold, you get paid fee-for-service, but they withhold 5% or 2% on every payment. So think about how you're going to handle the billing and the booking of that. How do you book the bonuses and the savings? Remember, a simple bill is a simple payment, so that's why a simple billing model would certainly be preferable. This has a profound effect, though, on your analytics, and I'm going to illustrate this by just talking about the proration of payments. Think about using a KPI as your average reimbursement for a service in your fee-for-service world. Now, fee-for-service, your 835 ties your payment to the service. But what happens in bundled payments if you get a fixed fee for a series of payments? So consider this, and don't try to figure out all the details here. You'll get a copy of the slides, and then you can drill down on this. But think of my bundle I'm calling A1, which consists of these services, and under a fee-for-service world, these are the charges, my expected payment, my adjustment, for a $10,000 reimbursement for this set of services. So in fee-for-services, I know I'm getting $10,000, and I know exactly how the payment is allocated. But what happens in a bundled payment arrangement where, in addition to my template set of services, I have to do two more of these things, two more of these 1, 2, 3 services? I still get $10,000. How am I going to prorate that payment? And think of that payment here versus your expected payment. Now your metrics are going to be thrown off because it's driving your average payment down. Without getting into the detail of this, the point here is that processing your payments and how you allocate these are going to have a profound effect on analytics. And it's not just in payments. This is just one example of how bundled payments is going to affect your internal analytics, and you got to keep this in mind as you're going through your planning process. So now let's talk about managing costs. This is the key to staying profitable. The reality is that healthcare lags the rest of the world in cost management. You're going to be implementing new methods, new processes, and new systems to manage costs. And understanding and allocating these costs is really key. And that's why your new CFO from Raytheon, who eats costs for breakfast, is so important. I want to talk a little about how you're going to capture the costs as well. So when we talk about costs, we'll be talking about back to Econ 101. If you remember, direct costs are those costs you incur when you do the work. I don't incur implant costs if I don't do an implant. Indirect costs, I overhead. What it costs to keep the doors open. So when I want to allocate my costs, and remember, you're trying to allocate the cost to a particular case. Remember that graph on the inside, tattooed to the inside of your eyelids. How are you going to allocate your costs back to a particular case? Well, direct cost is pretty simple. If I got the implant, I know where the patient went to. But indirect costs are much more complex. This gets to an issue called, or a topic called activity-based cost accounting. I'm not going to go into what that is, but suffice to say it's an intricate method of taking your indirect costs and figuring out how to allocate how much of your lighting costs, your utility costs go to a particular case. And as time goes on, these are going to be more and more important in your cost reduction models. So we're trying to reduce costs and squeeze everything we can out of it. So we need to understand what our current costs are and then figure out how we're going to reduce them. Well, once we start standardizing care, we're going to reduce our costs because, quite simply, we're going to be doing fewer things. And so the supplies, for example, associated with doing those things are going to be fewer and therefore less. But once we start to standardize, say, our implants, and where we're buying them from, instead of buying 3 or 4 implants, buy 1 implant from 1 supplier, we have better purchasing power, we'll drive our costs down. Think, how often do you go about renegotiating your medical supplies costs, your office supplies costs? Look at your internal staffing costs, your utilities costs, et cetera. This is going to be an ongoing important part of keeping your costs down. And of course, if you implement new care protocols, a lot of them will automatically come with cost reductions. But the real holy grail in cost containment is cost elimination. Walmart is the key to that. They're always about low prices every day. Nobody buys as good as Walmart. But their key to success wasn't to figure out how to reduce costs, it was how to eliminate costs. And they did that by removing steps from the process. This is the kind of thing you have to think about in your care redesign. What do I really not need to do? And this is where your new CFO is going to come in. How many steps are you taking in the operating room? How many times are you going from the nursing station to the patient's room? All of these things are going to wind up being issues ultimately in trying to drive your costs down. So any step you can eliminate or combine into one is going to generate cost savings. And what you're doing in a lot of cases is what's called disintermediation, which is the idea of eliminating intermediates, eliminating third parties involved in things. So instead of buying things from a supplier, you may choose to buy things directly from a manufacturer. Now, in addition to managing the costs, you need to capture them. So we're really good at charge capture, but what do we do about cost capture? We've got to be doing this on an ongoing basis. And I've talked about an idea that you may want to start with, which is assigning a cost to every charge graph as a primitive way of cost capture, but that really isn't the way to do it. You need to have methods of capturing costs in real time and giving real-time feedback. As costs start to mount on a case, it would be great if you could intervene early on in order to avoid things getting out of control, if possible. So this is going to require process changes, system changes. You're familiar with that picture right there. This is really a patient QC function to verify that I'm putting the right medication with the right blood type with the right patient. But there's also a way of capturing costs. But how about this? Capturing how many steps you took. Or this, every time you're using office supplies to attach to a particular case. Now, these are minuscule items you may think, but the process and the thinking behind it is what I want you to take away from this. How do you assign all of your costs back to a case in some way? At the beginning, they'll be general. As time goes on, you're going to get more specific. Now, what a lot of people will tell you is that in expanding the bundle process to fee-for-service, you're going to take a revenue hit. And this is one of the biggest objections from the CFOs in implementing bundle payments. And this is true, but it's the new reality. If you don't do this, you're not going to be around. It's just as simple as that. But bundling can also increase your cost if you start to add other scope of services. So if you start doing rehab as part of your bundle where you didn't do in the past, it increases your cost, but it increases your revenue, it increases your margin. That's all good. So finally, the last thing you want to do is monitor your performance. So what are you looking to do? Well, obviously, are you making money? And remembering that graph that's tattooed on the inside of your eyelids, where are my outliers? What's causing these avoidable costs? How can I avoid them? And I'm constantly looking to get feedback to understand those, to eliminate my costs, identify new revenue opportunities, find out where my patients and my customers are in the process, how they like what we're doing, and what could we be doing better, and then using all this information to renew my contracts with my payers on better terms. So this is all about continuous improvement feedback loop. I define my KPIs at the beginning, now I have to start to use them. So critical things might be readmission rates, it might be skip scores, There might be surgical site infection rates. It might be length of stay. A lot of these can be, like readmission rates, length of stay can be tied to financial savings that can be used in negotiations or bonus payments even. Patient assessments of how they feel they're doing along the way, and even provider assessments, how they think the patients are doing along the way. It'd be interesting to compare those two. Financial KPIs you may have might include things like your average cost per case, your average margin per case, or what % of my cases are outliers, and how am I driving that down? How about customer KPIs? And this could be customer satisfaction outcomes or customer satisfaction index that you would take by polling and surveying your patients. And then, of course, you need to have case managers in there. Their role is early intervention. You want to avoid those outliers and additional and unnecessary costs as much as possible. So you have to have somebody who's dedicated in monitoring these things in real time as time goes on as the episode and the bundle proceeds. You want to be able to give them tools and feedback tools so in real time they can find out what's going on so they can monitor the performance within the organization and also what the patient is doing. Is the patient feeling good about coming in for surgery? I don't want no-show surgeries, right? Is the patient staying on path for rehab, for medication, etc.? And this gets into driving new analytics that are called predictive analytics, which will help you understand your patients going forward and be able to identify high and low-risk patients before they start to incur the costs and go off the care pathway. And as I said, you want to use this for an ongoing set of analyses for your outliers. Your goal is to shift more patients back to the inside the bundle. Remember our chart? You want to take those guys and bring them right back in under the protective hood of your normal or your routine model range. Finally, you're going to reuse these results to renegotiate your payer contracts. Keep in mind that if your fixed price is $25,000 this year, at the end of the contract, they're going to come back and want it to be $24,000. What have you done to reduce your costs even more? Because you know that day is coming. You have to be constantly vigilant about doing that. So you need to get out in front of that. Today's threshold price is just a memory tomorrow. As I said, think about how Walmart buys stuff. It's this price today, it's that price tomorrow. Think about, and I come from Detroit, automotive companies. It's routine. They go in to their suppliers, they get them all in a big arena or stadium because they have so many. Say, guys, next year you got to reduce your cost 20%. And they're not doing that to be punitive. They're doing it to be competitive. So be prepared to be out in front of your payers wanting to reduce your costs and figure out how you've been creative to either reduce your costs or expand your scope. So we're ready to go. We figured out how we get started with visionary and inculcating a new culture into our organization. We figured out how to determine bundles, what makes sense to include and exclude. It's a new world of fixed price contracting. We've looked at different contract models, what's being done and where things are going. My personal bias, make your bundles as big as possible and go after it from a fixed price from the get-go. Workflow, my pet peeve, be sure it fits, be sure people can use it, or they're not going to use your new processes and systems, and you're going to see a lot of increased costs you don't want. Speaking costs, we learned about cost management. The key to profitability, we have to maintain our costs, keep them down. It's a continuous fight. And finally, we want to use all this information to see how we're doing. We find our KPIs up front. We want to use them to help understand how we're doing, how we can do better, and renegotiate our contracts. So I thank you for your kind attention and be happy to take any questions.
Thanks, Sheldon, for that informative presentation. We will be opening it now for questions. If you have a question for Sheldon, please type it into your questions box in the GoToWebinar panel on the right side of your screen. All attendees are submitting questions. I wanted to remind everyone that today's webinar is sponsored by Wellbe. Wellbe's Episode Performance Management delivers the tools you need to tackle the new world of accountable care. From pre-procedure preparation, inpatient care to home recovery, Wellbe's solution includes guided experiences for patient engagement, care coordination tools for team efficiency, and real-time analytics for episodic intelligence. To request an executive briefing on our solution, please respond to the poll on your screen. All right. Our first question is, will we get a copy of the PowerPoint? Yes, I'll be emailing a recording and slides out tomorrow. So watch for that in your email tomorrow. Sheldon, how are programs determining an appropriate distribution of shared savings among provider partners in the care continuum?
Boy, that is a great question. You hope you remember the presentation, that really is where you want to align the incentives. And it all comes back to the payment. So there's as many as you can possibly think, and even more coming down the road because everybody does it differently. So let's assume your physicians are all employees, okay, of your, and again, it depends on the organization itself, but your physicians are all employed. You can do it as a percent of the threshold savings, and this also depends, by the way, on your contract with your payer. So if you're doing one of the common ones where you're doing a shared savings model, you're going to share a percent of the savings among the providers based on, and you got to determine how you want to do this. You can do it based on contribution of top line revenue, okay, number of cases done. You can do it based on that plus quality metrics, which can be some of these KPIs, including patient feedback. You can, well, and then you can see you can do it based on any one of those types of combinations. So you can do it based on the financial KPIs and the quality KPIs and any other ones you want to put together. You can do it on subjective ones like customer satisfaction and even staff satisfaction indexes you can do by survey. So the idea is you got to find some type of set of thresholds that everybody can agree on that comes right up front, okay, and then you build the KPIs to measure those. And then I would suggest you get a third party who amalgamates all the data and then distributes the checks out, just so you're sure. This is especially true when you're using multiple organizations as part of the bundle, so that everybody has confidence that there's an independent third party distributing that. So I wish I could say that there's just one way to do it, but there really isn't, and everybody has to get together. And again, it's a win-win. And whatever distribution model you use, you want to be sure that everybody's got skin in the game on this. So use some quality metrics and use some feedback metrics as part of this, and not just financial/production metrics.
Great. Scott asks, how much are payers helping with monitoring performance?
Monitoring performance. Well, what they will you know, they have skin in the game. They absolutely want this to work. What they will do is they will share data with you. So the kind of data that you'll get will be claims data. That's what they got. In terms of monitoring performance, again, it's all going to come out of claims because that's the data that they have to share with you. If you have some ideas about how you want them to participate in that, I would not be shy about bringing it to the table. Because again, it's a win-win, and they're looking for providers to help out in this. They've got plenty on their plate just trying to run these programs, but if you can do things to help make that easier, especially in monitoring what's going on, that's just a plus to them. Now, if you're looking at monitoring patient performance, I don't know of any payers that are directly doing that other than just small initiatives they're trying to launch out there to see what happens. If you talk to the folks at WellBe, I'm sure they're in touch with payers who are looking to sponsor maybe some of this to try to help out certain bundle payment providers in doing that. So if they're not doing something now, I would not be shy about approaching them to either fund the types of things that you need or some other way to participate in that. Again, it's a win-win. And keep in mind the payers are on board with making this a success. Negotiate that to the max.
Okay. Kathleen says she's looking at CMS bundled programs as well. And would you use the same approach dealing with Medicare?
The same approach, a little unclear. Do you mean the approach in terms of the deals? They already have preset models. If you're talking about going to their model, or the model forward or fully risk is the one I like most, but you're kind of pigeonholed in that. If you're asking whether you should use those same models going to commercial payers, my personal bias, again, is not to go to that type of shared savings model. It's to be more aggressive and go to a direct fixed fee model. Again, it's riskier, but you have more control over what's going on, and you have a lot more upside. So that's my personal bias in doing this thing. If you're more risk averse, and in healthcare we tend to be that way, and if you are, then the types of shared saving models that they put forth are generally the way these things will play out, because you'll be going to billing a fee-for-service model. You're going to establish a threshold, a mutually agreeable number that's going to be based on historical data that the payer and provider are going to work to determine is acceptable to both. And then you'll do these, as I explained, these true-ups on a periodic basis, which again are costly for you and are costly for the payer. So again, I like those fixed price models because it saves them a lot of work, and it also gives you a lot more leverage to negotiate things away. So again, administrative simplification. Remember the invoice, the claim versus the commercial invoice? I would negotiate that one, aggressively with my payers to quit sending claims. If you want me to go at risk and take on the full boat for a fixed price, this is my aggressive stance, you don't need details about what I'm doing, because you can come and audit me, but I don't need to send you claims detail. I can send you a single line item, make my life easy, make your life easy, and I'll be willing to take on the risk. So that's how I see it.
Hey, we're running out of time at the top of the hour. Maybe we'll ask one more question. Jeff wants to know, can you describe the interplay between ACOs and bundle payments?
Yes.
Can ACOs participate?
Yes, good question. Bundle payments are a tool that an ACO uses to offload risk. That's the simple answer. An ACO is both a payer and a provider. It takes risk from an insurer, let's say, or an employer for a population. And let's take a simple example. Maybe they take, an $800 PM, not PMPM, but a fixed fee to take a PMPM, let's say, to take care of a patient or a group, obviously a group of patients. So now they're on the hook taking the risk. So the ACO may have its own employee physicians, and it may have subcontracted physicians in hospitals as part of its network. What it'll do is it'll go to an orthopedic group and say, listen, I would like you to engage in a bundle payment with me for total joints. And you would enter into a bundle payment arrangement with the ACO. So to the employer hiring the ACO is a provider. To you as an orthopedic practice, the ACO is a payer. The ACO is using the bundle payment to fix its cost, its internal cost, vis-a-vis its contract with the employer. So bundle payments is a tool that an ACO would use to shift its risk downward.
Great. Well, that's all the time we have for questions today. If you have questions you didn't get a chance to ask or have answered, feel free to email them to info@wellbe.me, and I'll get back to you. I'll also take the questions that we didn't have a chance to answer here and share them with Sheldon. Everyone watch your email tomorrow for a link to the recorded presentation and PDF of the slides. Thanks, everyone, and have a great day.
Thank you. Thank you, Megan. Thank you to Wellbe. Enjoy your day.